Good morning, everybody. Good afternoon. I'm excited and thank you very much for people who have been here already. And I see people from Buguruni. Yay. I see Mr. Yes, welcome, Mr. Siaka, Mr. Jafari, Dr. Akida, Dr. Robert Mushio. Oh, great. Dr. Ian Sambichaka and Mr. Johari, Dr. Benera. Whoa, okay, we are good to go. So it's almost 15 people, and anyway, we are so excited today. We have our esteemed presenters, and I'm like, I can't wait. As a labor and delivery nurse taking care of the mom and babies, this is the class to be. And if you really want to be able to worry about the baby and prepare for the baby, and for all this neonatal topic that we've been learning, you need to be in this class to know how mommy is doing and how the baby is doing for us to prepare and be ready for that baby. So we do have Dr. Emma Mugeri, Professor Michelle Brown, and Mr. Jafari Rutavi. So we are so excited that all of you are able to come in. And so, of course, you know, from US, the way we monitor the baby is we have quite a bit resources to monitor the babies. But today we are trying to incorporate what Tanzania is using to monitor. So I am hoping at the end, and I appreciate for everybody who's here, I'm hoping at the end that people have questions to ask. If yes, if in US you can monitor using this electronic fetal monitoring and all the fancy stuff, what happens if you take that technology out and then put that baby in Tanzania and put that mom in Tanzania? Those two moms, mom and baby, should have the same care to make sure you monitor the mom, monitor the baby. So the presenters are going to be able to give us a little few insight to make sure that we can address the mom, we can address the baby to make sure that they're able to take care of this mom. So, okay, guys, as I said, we're excited and thank you everybody for being here and being here this early in the morning or late mid-afternoon for people in Tanzania. Okay, so as I said, when we're talking about the fetal monitoring, you're trying to check and see what baby tells us, as Mr. Jafari puts it, what baby tells us before the baby comes out. So we need to prepare for that baby. I am gonna give at least 1 minute to each of the presenters to introduce themselves, and then we're gonna start right away. So I'm gonna start with Professor Michelle Brown, although her name says Andrew and Michael. Go ahead. That's how I
keep forgetting to change that.
That's okay. You can say hi and then you can go back. Yes.
Okay. Good. Hi, everybody. Nice to be here. Thanks for having us. I'm really excited about this class because, you know, moms and babies are what we love to do. So thank you.
Thank you, Professor Brown. Mr. Jafari, you want to say hi?
Yes, hi everyone. My name is Jafari Rutavi. I'm a midwife from Muhimbili National Hospital here in Tanzania, and I'm so happy to join you guys. Today, I think we learn more about on how we can monitor our babies, neonates before delivery. Thank you.
Thank you very much. We are so excited. Dr. Emma?
Yes, hi everybody. I'm very happy to be here too. I am an obstetrician and gynecologist, and I am based here in Greensboro in North Carolina. Originally, though I'm from Tanzania, that's my home country. I came to this country when I was very young. I came after high school. And so, you know, I went through medical school and, you know, obstetrics gynecology training, and then I've just continued working here. But my parents still live in Mwanza. I have a lot of siblings in Dar es Salaam. So I come to visit Tanzania every now and then. That's still my home. So I'm very happy to share what I know with my people from Tanzania.
Thank you very much. We're so excited. I can't even sit still, but thank you very much, Dr. Emma Mugeri, and we are ready to go. So with the way it's going to be, Dr. Emma Mugeri is going to start, And then we're going to have Professor Michelle Brown continue giving us the nursing interventions. How should we need to do when you realize that baby is not doing well? What do we need to do? Prepare for that baby before they come out. And then Mr. Jafari is going to tell us, give a real 2 case study to walk us through how the baby did during labor and then until delivery, and what were the outcome and what intervention could have been done or what intervention were done to prepare for that baby and take care for that baby. So I am excited. So without delaying, I am going to try to play the video so you can have the idea what exactly we're thinking about these babies. So let me go back to my, doesn't have an audio, it just give you the idea. And Professor Brown, if you can interject any information about just to show how the video goes and then what you want people to get out of it.
Okay, is it going to start? Okay, there we go.
Yes.
So this first slide just shows how the uterus contracts and the pressure that the baby feels during the contraction as the baby pushes down in the birth canal. So you can see the baby in relation to the cervix and the cord. And we hope that this cord doesn't get all tangled up on the baby. Okay, and this slide just shows the cell level of the oxygen being transported and the carbon dioxide going from mom to baby and baby to mom. You can see as the uterus contracts, a lot of times that slows down the flow of oxygen because of the pressure in the uterus. So again, this is just showing what the contractions effect is on the blood flow. You have to wonder what those little babies are thinking during this time, don't you?
That's why they don't want mommy to be contracting unnecessary.
Right. So lots of increased pressure in the brain and the head as the head comes down in the birth canal.
And those corn heads. Always babies like, what are you guys doing?
It's just a different way of showing the pressure on the baby's head that goes along with each contraction.
And that's why usually we don't want the mom to contract unnecessarily or prematurely or for too long laboring. Then you have to think of the baby, how the baby's doing, because all that much pressure for that long, you labor the patient for a whole day. What do you expect the baby is going to come out to be? So we always have to think of that. So those contractions should be effective versus just let the mom contract without any reason.
And that's why we don't want the contractions to be too close together either, because we want the baby to get a break in between so that they can reoxygenate. This just shows a quick view of a contraction pattern, the normal contraction pattern, but I know there's some different slides in Dr. Emma's presentation. You'll be able to see it a little bit better. But you can see that there's a rest in between these contractions.
the reason that we want to show you that video is just to create that basic information. Every single time you see mom is contracting, think of that baby. So does mom have effective contractions? Thinking of that baby. So what do you need to fix that baby before the baby comes out? So usually we don't like those moms that have premature contractions. We have to be able to address that. So I am gonna invite Dr. Emma to start and give us a little background and interpretation of the tracings. Go ahead, you can share your screen.
Okay, thank you. Before I share my screen, I just want to say a few days ago, I was on call and I was at the hospital and I got this frantic call from the labor and delivery floor. They're like, Dr. Kulwa, room 203, cord prolapse. So I tell them, meet you in the OR. And I rush down the hallway and they are also very fast. They're already in the OR. And I go ahead and we do an emergency C-section, and thank God, baby comes out well. Up girls are like 5 and 9, and baby's good, mommy's good, and everything turns out to be okay.
Wow.
And so what happened in this case? This was an emergency. As you know, cord prolapse, you need to act quickly. But this patient, the only way we knew that she had cord prolapse was because she was being monitored. She had been there in labor and was progressing well. You know, her water had been broken. She was comfortable lying in bed, sleeping, and did not know that anything was happening between her legs. Thank God she was on the monitor. The nurse saw some drops in the baby's heartbeat and was like, well, let's check this young woman, what's going on in there? And when the nurse checked her, she felt that cord prolapse. And that's when she activated all the events that happened. So what if this woman was not being monitored? What if she was comfortable and sleeping away and the nurse was saying, well, I'm gonna check her in about 2 hours? Something could have happened to this baby. With a cord prolapse, every minute that it's happening increases the risks to the baby. So this was one time that I really felt very happy that this patient was being monitored, and it really just reinforced to me how useful fetal monitoring can be. Fetal monitoring has been shown to decrease mortality during the intrapartum period. So let's talk more about fetal monitoring. What is?
Yes.
Okay, good. All right, so I have no financial disclosures. And I'm going to focus on interpreting and managing of the fetal heart rate. So as Dr. Harriet and Dr. Michelle Brown did say, you know, during labor, the contractions will usually cause the blood flow to the uterus and also blood flow to the baby to be decreased a little bit. And most babies can tolerate that. However, some of them may struggle and then their heartbeats may drop. And that's what we want to kind of pick up on. The fetal heart rate monitoring helps us to identify the babies who are able to tolerate labor and those who are not able to tolerate. And so for those who are not able to tolerate, then you can do interventions early on that would hopefully prevent them from getting to the worst point where maybe, you know, they don't have enough oxygen and they become acidotic and now their brains are being affected, or even worst case, they're now dying. We want to prevent all that. All right. Okay, and so as much as you want to identify the babies who are, I guess, having a hard time tolerating this labor, you want to identify the babies who are doing well, who are well oxygenated, so that you don't do any unnecessary interventions. In the United States of America, most women will have what we call continuous fetal monitoring, where they put the probes on the mother, and it stays there the whole entire time, maybe except when mom has to go to use the bathroom, or but it stays on her for most of the time. However, not everybody needs that. So then they do say, American College of OBGYN says you should definitely do continuous monitoring for high-risk pregnancies. If there is any growth restriction, if there's diabetes, if there is preeclampsia, But also, if the pregnancy is not complicated, if the mom wants that, you could also do continuous monitoring. And most people do want that. Most patients do want that. Other institutions like the National Institute for Health and Care Excellence have said if mom has severe high blood pressure, if you're using oxytocin, if there's any infection in the baby, if there's any infection in the uterus, chorioamnionitis, then you should also consider continuous monitoring, significant meconium or active vaginal bleeding. In that case, you're suspecting things like, I don't know, placenta abruption. And so essentially, we do have those probes that you would place on the mother's abdomen. And then you do have the straps that you put around the mother and that keep it in place. And so you do have one here, which will pick up the baby's heartbeat. And then you have the one at the top that will usually pick up the contractions, the pressure from the contractions. And you can see how they're all connected to the machine on the side, which then will record the baby's heartbeat over time. And you can see the machine here kind of printing out the heart rate as well as the contractions over here. And this can also be transmitted to the computer that can show the heart rate up top, but also the contractions at the bottom. And usually the computer is at a central location, maybe at the nurse's station, so the nurses can look at it without necessarily having to be in the patient's room, but also it may be in the patient's room. And so as we are looking at the baby's heart rate, we want to determine how is the baby's heart rate? Is it a good heart, is the tracing a good tracing or not? So essentially, there is an organization called the National Institute of Child Health Development, NICHD, that has met up several times, and they have defined what is a good tracing and what is a tracing that you should be concerned about. And I hope you can see all these small readings, but category 1 is the best tracing. This one usually shows that the baby is doing well. You want the baseline of the heart rate to be anywhere between 110 and 160. You want, and I'm going to jump onto this one so you could see this heartbeat, this tracing below here, where the baseline is about 140. And then you want it to have a moderate variability. Variability is looking at the beat-to-beat changes in the baby's heartbeat, and ideally should be anywhere between 6 to 25. And so essentially you want to see that it's it looks like a saw tooth, like it's up and down. So this one has good variability, moderate variability. And then that you have no decelerations. You don't have any late or variable decelerations, which may indicate that the baby is not doing very well. Early decelerations are okay to have. Early decelerations usually happen with compression of the baby's head. And those are fine. You know, that's going to happen as the video showed initially. Late decelerations, essentially you have those dips in the baby's heartbeat after a contraction. And that can indicate there is a problem with the placenta, that maybe the baby is not getting enough blood flow through the placenta. But also variable decelerations means maybe that there is umbilical cord compression. And those ones are usually sharp and they are very abrupt. So you don't want to have any of those if you are thinking that the baby has category 1. Accelerations, which are increases in the baby's heartbeat. You could see one over here. From the baseline, it kind of goes up and then kind of goes back down again and then up again. And you want to, you could have them or not have them. But the most important thing is the variability is moderate. Now, the tracing that you don't want to see is the category 3 tracing. And these ones usually are predictive of abnormal fetal acid-base status at the time of the observation. And these are the ones that you want to monitor even more closely. You want to do the interventions to make it become better and actually consider how soon or how quickly can you deliver this baby if the tracing does not improve. And these ones are the ones that have absent variability. And I'll show you another image later on. And then you also have recurrent late decelerations. With every contraction, you can see the heartbeat dropping for the baby, or you can have recurrent variable decelerations. If you see bradycardia, the baby's heartbeat is less than 110 and it's staying low continuously for more than, let's say, 10 minutes, that could be bradycardia. And then also if you see sinusoidal pattern, that is where the baby's heartbeat almost looks like a sinusoidal pattern, kind of going up and down. And I'll show you a picture of that too. And then the category 2 tracings are the ones that fall in between category 1 and 2. And that's the biggest group. And it involves a lot of other tracings, which don't fall into category 1 and 2. So we've talked about category 1. And essentially, it indicates that there is minimal likelihood of any ongoing fetal hypoxic injury. It shows that the baby is well oxygenated, that really the baby is doing well. Okay, category 3, like I said, these are the abnormal ones, and they are associated with an increased likelihood of fetal hypoxia and also metabolic acidemia at that time. Okay, so it doesn't mean that it is 100% associated with, however, it says increased likelihood of that. Like I said, you would have absent variability and then those recurrent decelerations. All right, so I do have the picture here that shows, you can see the baseline is almost like a straight line. You don't have that jagged sawtooth. And then you can see the decelerations are happening after the contractions. So this is the one that measures the contractions, and this is the heartbeat. And you can see there's a contraction here, but the deceleration is happening right after the contraction. Again, a contraction here, and then you have a deceleration. So these are recurrent late decelerations. This is a category 3 strip. We have another one here where also it almost looks like a flat line. So there's absent variability. And then you do have those decelerations, which are very sharp and they are very abrupt. These are those variable decelerations. So you could see that right there. And then again, right there. So that's also category 3. And then this is the sinusoidal pattern. It just kind of goes up and down. You can't really detect the baseline. This is also a category 3 tracing that you need to act on quickly. So, like I said, yep, you want to take measures to improve oxygenation of the baby and even consider quick delivery. However, not all category 3 tracings not all category 3 tracings directly mean that the baby is hypoxic. Other conditions that may cause a category 2 or 3 tracings include baby sleep cycle. Maybe the variability may go low. Usually, however, it will cause minimal variability, not necessarily absent variability. If there is problems with the monitoring, if there is the problem with the electrode, with the monitor, what if the nurse has set the setting wrongly? Instead of for it to record at 1 centimeter per minute, instead of 3 centimeters per minute, maybe it's been set wrongly to 1 centimeter per minute. So that could also give us a false reading. So all these things would have to be checked if we are suspicious that there is a category 2 or 3 tracing. What if the mother's heartbeat is the one that's being checked? Then if you're not so sure if you're detecting the baby or the mom, you definitely want to maybe check the mom's radial pulse. You may want to do a pulse oximeter on the baby or on the mother, and that would tell you the mother's heartbeat. You may want to do an ultrasound of the baby, and you could see the baby's heartbeat directly. And you may also want to do what we call an internal scalp electrode, where you put a little hook on the baby's head, and it will tell you the true baby's heartbeat. If the mom has received other medications, such as narcotics for labor pain, Stadol, all of those can affect the baby's heartbeat. If the mom has preeclampsia and now they're getting magnesium sulfate, that can also affect the baby's heartbeat. there is a medication called butorphanol that we use a lot for pain that can cause a sinusoidal pattern. So if you notice that sinusoidal pattern right after you've given that butorphanol, then you probably want to give the baby a little bit of time to recover from the butorphanol before rushing to do that C-section. Whereas if the mom walked off the street and you put on the monitor and she has this sinusoidal pattern, that's more concerning because she hasn't received anything that would make the heartbeat be that way. Beta blockers and atropine can increase the heart rate. If mom has a fever, that can also cause the baby's heartbeat to be high. If the baby has some arrhythmias, you may also see changes in the baby's heartbeat. And so if you're suspicious of an arrhythmia, you probably want to do an ultrasound because you can see that the baby's heartbeat better that way. If the baby has any pre-existing fetal neurologic injury, then you'll also see changes in the baby's heartbeat. And usually those ones, when they come in, you would probably notice that from the get-go, because a lot of these neurologic injuries will happen even before they come in labor. And so, as you know, the baby's brain works in conjunction with the baby's heart to determine how the heart rate goes. So if the baby's brain is already compromised, then the heart rate may also be compromised. And so in that case, you may see tracing where there's no accelerations and where the baseline is fixed and, not really variable, flat. So that could also be a reason for the category 3 or 2 tracing. And so with category 1, we know what to do. Everything is good, continue with routine monitoring. Category 3, hey, let's resuscitate the baby. Let's think about delivering the baby. All right. And then what about category 2? So these are the ones which can be a little bit more tricky, because they're in between category 1 and 2 and 3. They're not normal, but at the same time, they're not abnormal to warrant like immediate delivery. And they're very common. Actually, a lot of babies will have category 2 at some point. And so you really want to manage this category 2 tracings with a careful assessment of the whole picture. Is it category 2 and is it bouncing back to category 1 every now and then? If it does, that's reassuring. You can continue with the labor. Or is it category 2 and maybe those variable decelerations are deepening or becoming more frequent over time, even though it still remains category 2. In that case, you may still want to go ahead and consider delivery, even though it's still category 2. So you can have to look at the whole picture. So how do we clinically approach these abnormal fetal heart tracing? And I think Michelle will talk more about this too. But briefly, like I said, you want to be sure you are picking up the baby's heart rate and not the mom. You want to be sure that you can see the baby's contractions and you can assess the heart rate in relation to the baby's heartbeat. All right. So if you don't have a category 1 tracing, you want to try to improve the fetal oxygenation. And some of the things that you could do are, you could maybe change the mother's position. Maybe put the mom on her side. As you know, putting the mom on her side relieves compression on the major vessels that run on the back of the mom. So there's more blood flow to the uterus, more blood flow to the baby. You want to give her some IV fluids that will enable more fluids to be getting to the baby and hence more blood flow. If they are having very frequent contractions, you may want to give them something to stop the contractions like terbutaline. You may want to do what we call fetal scalp stimulation. Let's say if the baby is not having any accelerations, you want to examine the mother and scratch the baby's head. Ideally, you should see the heartbeat increasing, and that would reassure you that the baby is doing well. All right, and like I said, you also want to see the progression of everything. If you're seeing deepening decelerations and longer decelerations, less variability over time, all those would indicate you need to go ahead and deliver. And so you always also want to check the mom. What if she's having these decelerations and now she is 10 centimeters dilated, and maybe instead of doing a C-section, you could do a vacuum delivery. And so you do have to assess what you have as your facility. Where is the doctor? Is the doctor 20 minutes away? Do you need to call them in advance and give them a heads up? Hey, we're having a category 2 tracing. You better come to the hospital. Do you want to let the operating room know we might need to deliver this baby quickly? Do you want to have the patient sign the consent forms for the C-section? So all those are very important. This is just another table that talks about those measures that you could do to help with the category 2 and 3 tracings. And so in summary, fetal monitoring is just a screening test for interrupted fetal oxygenation. It's a screening test, meaning it's not 100% diagnostic. And so if the fetal heart rate is normal, that's reassuring. The baby's doing well. But if it's not normal, it doesn't 100% mean that the baby is not doing well. That is when you have to look at the whole picture of the presentation. You have to do those other extra tests, do your interventions, and then kind of act from there. And so I really do believe that it's helpful. It has definitely been shown to decrease mortality of the baby during the intrapartum period. As far as, let's say, neurologic injury to the baby, I don't think it's been shown to be necessarily helpful in preventing that, because a lot of these neurologic injuries will happen even before they present in labor. So I think it's a wonderful gadget to have, and I am done with my presentation. Any questions?
Yeah, we're going to save all the questions at the end so people can hear all 3 areas and then answer those questions. So you might have a question which probably Professor Brown is going to answer it. So we're going to save the best questions for last.
Okay. Thank you very much, everybody.
Thank you very much, Mark, for giving us the background. And at least now we know we can identify or interpret those tracing. So then as nurses, we always know, okay, so what am I going to do about it?
Yes.
Professor Brown is going to help us to do that. So if you stop.
Okay, so hello again, everybody. I am a nurse. I've been a nurse for 46 years and always taking care of moms and babies. And as well, I have no financial disclosures in this process.
Oops, we did see the video already. Okay, go ahead.
So because I've been a nurse for 46 years, when I started my career, we didn't always have fetal monitors. So I think that's probably why Dr. Gabon asked me to do this, because I've worked in those same conditions as not always having a fetal monitor. So a nurse's touch and presence is so important, especially when you don't have fetal monitors. So when the patient comes in to see us, we want to get to know them, and we may have their history or we may not have their history. So we have to start asking them questions as we're getting them settled and comfortable. So I like to start with, how are you feeling today? When did your contractions start? Are you having any bleeding? Or are you having bloody show, which is the blood mixed with some mucus? And then that gives us an idea of what we're going to look for further as we're talking to our patients. We also want to know, did their water break yet? Did they have rupture of membranes? And what time did that happen? Because we don't want that to go on for a long period of time. So we kind of want to know when their water broke. What color was the fluid that came out? Because again, that's one way that the baby communicates with us to tell us that they're doing okay, or that they're having some stress. So if the fluid is colored or green or yellow-green, then we know that at some point the baby's been a little stressed. And that's another clue onto how we're going to take care of the baby. And is there an odor to that amniotic fluid? because that's a sign that there could be an infection going on, either for mom or baby. So those are all clues that are going to help us in caring for that mom and that baby. Okay. So now, because we don't always have a monitor available, we're going to use our hands, and our hands are very important. That's the tool that we have if we don't have electronic devices. So we're going to actually palpate with our hands her uterus to feel those contractions. And we're going to do that at the top of the uterus, because that's where the uterus is thick and we can really feel the muscle. It's a non-invasive procedure. We just have to explain to the patient what we're doing, let them know that we're going to have our hand on the top of their uterus and we're going to be feeling their contractions. We want to know, how close are those contractions? How long do they last? How strong are they? And does the uterus relax between the contractions? As we mentioned earlier, we want that uterus to relax between contractions so that that baby gets a little bit of a break and can reoxygenate itself. So it's really important that we ask these questions and that we touch the uterus. I know a lot of times I work with nurses now that they don't touch the patient anymore. All they want to do is look at the electronics. But I think they both go together. You have to use all of your tools together. So right now we're going to use the tool of our hands and we're going to palpate. So I'm sure that you all have felt contractions. We want to know if they're mild, moderate, or strong. And there's just, a little something that I tell my students: if you touch the tip of your nose, that's a mild contraction. If you touch your chin, that's a moderate contraction. It's a little bit firmer. And if you touch your forehead, that's a strong contraction. That's actually how firm the uterus is going to feel with a strong contraction. Okay.
Like that.
You can go back to those pictures.
Sorry.
Thanks. These are some different tools that we can use to listen to the fetal heart if we don't have a fetal monitor. So some of you may have used these. The one in the top middle is a fetoscope, which is probably the most common. And it's just a specialized stethoscope that we can use to actually listen to the fetal heart tones. And we place that long black part on top of our forehead, and then the bell on top of the uterus. And that uses bone conduction to allow us to hear the fetal heart tones better. Okay. So before we listen to the fetal heart tones, we have to know where the baby is. Is the baby head down or feet down? So again, the way we're going to determine this is with our hands. Our hands are so important to palpate the uterus. So we're going to feel, it's called Leopold's maneuver if you do all 4 steps. We're going to do a modified Leopold's where we feel down the sides of the uterus, and we're going to listen to the heart tones on the side that feels the firmest. And that's going to be the fetal back. And that's going to allow us the best place to hear the heart tones. So again, this is a non-invasive procedure. So we're going to listen to the fetal heart tones, but we're also at the same time going to check mom's pulse. Because as Dr. Emma said, we want to make sure that we're listening to the baby and not to the mom. So we're going to do both of those at the same time to start with. Once we've determined that we truly have the fetal heart that we're listening to, then we don't need to listen to feel mom's pulse at that point. Okay. So when are we going to listen to the fetal heart tones? Now, if we have a fetal monitor, we're going to put the monitor on and we're going to get a nice strip so that we know how the contractions and the fetal heart tones relate to each other. But if we don't have a fetal monitor, when are we going to listen? Well, as soon as mom gets there, we're going to listen because we want to make sure that that baby is doing okay in that moment. So we're going to listen to the fetal heart tones as soon as we can. And that is good. If mom is not having contractions, That's going to give us what we call the baseline that you could also see on the fetal monitor strip, which is the heart rate between the contractions. And it's important to know the baseline so you know where you're starting. Then if mom has a rupture of membranes or she breaks her water, we're going to listen to the fetal heart tones right after that. We want to make sure that the cord didn't come out in that cord prolapse that Dr. Emma was telling us about. We want to make sure that that didn't happen when the water broke. So we're going to listen to the fetal heart tones right after the water breaks. And then if mom's in labor, we're going to listen. We've already established our baseline. Now we're going to listen before the contraction, during the contraction, and after the contraction. And that's not always an easy thing to do with a fetoscope. Sometimes, even though it's non-invasive, sometimes it's a little annoying to mom because she's busy having a contraction and now you want to be there on her uterus with the stethoscope listening to the baby. But it's important that we listen before, during, and after the contraction, because that's how we're going to pick up a change in the fetal heart tones. So then we have to relate those changes to what Dr. Emma talked about with the fetal monitor. Is it a variable? Is it cord compression? Is it head compression? Is it a late deceleration? So then we adjust our listening to where it is with the contraction, before, during, or after. So it's really important to listen all those times. And we listen for at least a minute just to get the full picture, okay? And then if you're listening before, during, and after the contraction, of course, it's going to be longer than a minute. Oh, sorry. Thank you. I was trying to change it. Okay, so when do we listen? How do we listen? When we have a professional organization, it's called AWON for the nurses, the Association of Women's Health, Obstetric, and Neonatal Nurses. So any nurse involved in the care of moms and babies can belong to this organization, but they publish guidelines that kind of drives our practice. And they work with the physicians organization, ACOG, so that we develop these standards of how we take care of our moms and babies, so that we're all on the same page and doing the same interventions. So the nursing interventions for the fetal heart tones, how often should we be listening? If we have a low-risk patient, means she doesn't have risk factors, and she's in early labor, then we're going to listen every half an hour. When she starts to push, we're going to listen every 15 minutes. Now, those seem to be not very often. So you know your patient, and you might want to listen more frequently, even if your patient is low risk. It doesn't hurt to listen more frequently than the guidelines state. Okay. If our patient is high risk, then our guidelines say that we're going to listen more frequently, because remember, we don't have the patient on the fetal monitor, so we're not capturing each and every heart rate and each and every contraction. So we want to listen at least every 15 minutes while they're in labor, and then every 5 minutes when they're pushing. If they have any kind of medical situation going on, I want to listen with every contraction, if at all possible. And then that depends on how many patients you have and how often you can be in the room with that patient. But our guidelines say at least every 15 minutes in labor and every 5 minutes when they're pushing. So what are we going to do when we hear a heart rate that isn't within our range, the 120 to 160 or 110 to 160? What are we going to do when we hear that decrease in the fetal heart rate? One of the first things that we can do is to change mom's position, because maybe the cord has become compressed between mom and the uterus. So we want to change her position and get the pressure off of that cord. We can also hydrate mom. If she has an IV, we can increase the rate of the IV fluid. We don't want to give them a lot to take. I'm not sure what the practice is there if you allow them to eat or drink during labor, but maybe they can have some fluids to increase their hydration because, you know, they're working, they're doing a hard work. They're going to get dehydrated very easily. Other things that we can do to help mom is to help with her breathing so that it stays even and steady. If you have oxygen available and if that's part of your practice and you have an order for it, you can provide oxygen to mom. That might increase oxygen flow to the baby. And then whatever is causing your decelerations, you have to treat that cause. So if it's head compression, because we have heard a decrease in the fetal heart rate before contraction, then maybe we want to again change mom's position. Oftentimes that's the easiest thing to do. If we're hearing a deceleration after the contraction, that is a late deceleration. That's placental insufficiency. So there's not always a lot we can do for that except prepare for delivery. And anytime we hear an acceleration, an increase in the baby's heart rate, that's an encouraging sign to us. That lets us know that the baby's kind of happy hanging out in there and it's going to be okay for a little while. Okay.
Thank you very much, Professor Brown. And at least now, as nurses, we have some guidance what exact things we need to do when that baby is telling us a story. And then so we need to be able to prepare and then communicate with our providers if they need be getting more orders. So thank you very much for providing that. I'm going to let Mr. Jafari now give us like how exactly we can do to this case study that he prepared for us. Mr. Jafari.
Hi, everyone. Good morning and good afternoon again. So I'm here just to show you two cases. It's a case studies that we are going to see on how the fetal monitoring have been done and the action that will be taken in case of we notice any variation which is not normal. Mr. Jafari Lutavi, as you can see the description there, a registered midwife. I work at Mwambiri National Hospital and master trainer of HMIS and HBS as well, and neonatal care, also a basic obstetric ultrasound and so on. So these are tools that we are using here also in our context as Tanzania. So we are using fetoscope, but we have other different types of instruments or devices that we are using for monitoring fetal heart rates. That's including Moyo, and we have a CTG as well. So our case for today, we are going to see the continuous monitoring of the patient by using our CTG. So we had interpretation knowledge before from Dr. Kulwa. And so I think for now we are going together in this case. But also I have to remind you that I have any financial disclosure. And we have a case of a female who is 29 years old. She's gravida 2, para 1, living 1, and present to labor and delivery with 30 weeks and 2 days of gestation age, with a deceased fetal movement. That was a main complaint. She had noticed a deceased fetal movement 5 days earlier and had a non-stress test the previous days that become reactive after almost 2 hours of monitoring, and many attempts at fetal stimulation were done. She's also received no other evaluation at that time. Otherwise, had no complaint and denied any complication, contraction and vaginal bleeding or PV leakage. As you know, this patient had also obstetric history of full-term delivery previously, but she had a complication of preeclampsia and with severe features. So currently she's just came with labor pain and also has a medical history of vascular necrosis of a femoral head, and she had no any other medical concern apart from that. So according to the history also, our family history was noticeable for her brother who had a recent diagnosis of autoimmune clotting disorder, and he's on treatment with warfarin. Also, this patient has reported that her brother was doing well and no any information regarding his diagnosis. So as you can see, we had just a simple history of this patient, and after receiving in labor ward, the fetal monitoring were done, and as you can see the graph there. So according to the finding of this graph, you can see there is no viability, and the baseline fetal height, because it's not seen clearly, but it's 140, and she had an episode of sinusoidal, and even the uterine contraction, when you check the lower part of the graph, you didn't find any contraction by that time. So on interpretation on this, we found out that this is category 3. If you remember on Dr. Kura's presentation, that's on categories. So this is category 3 because there is no variation. There's no viability, and also there is a sinusoidal heart rate, which is in category 3. So the tracing, according to this tracing, this is an emergency and need an urgent action to take out this baby. And this is tell us that there is maybe a fetal hypoxia, and it possibly that, as you can see on the video that Professor shows, we see there is a reduced amount of blood supply to the baby. So somehow, and this is called fetal hypoxia. So concerning on the worsening of fetal status, of the obstetric team are supposed to do an urgent cesarean delivery, and as you can see also in this chart here, sorry, I can't show you directly because I'm just using an iPad, so I can't show by. So here, as you can see, there is no contraction, and this is also category 3. So the plan was to do cesarean section to this woman, and the urgent cesarean section were done, but neonatology was there as well, and she had a female baby, 2.5 kg, with APGAR score of 6 in first minute and 8 in 5th minute, but also 8 in the 10 minutes. So the baby was appeared extremely pale and required intubation immediately after delivery, and she was also given a blood transfusion in a via umbilical vein, but also transferred to special nursing nursery care unit in a stable condition. So as you can see, in a post-delivery, there is abnormal coagulation studies that were done, whereby there is an elevation of prothrombin time and partial thrombin time, also ANR. But also it is decreased fibrinogen level, and there is normal platelet count. So what does this tell is whereby the brain ultrasound done 2 days after this birth show a marked amount of complex extra axillary fluid and moderate ventriculomegaly, as well as abnormal appearance of gray and with citric encephalomylacia of the left tip parietal lobe. Also, there is a hemorrhagic ischemic changes in the left tip parietal, the occipital and temporal lobe. So according to these findings, it tell us that this baby had a cerebral hemorrhage. So this is what caused anemia. And as we can remember on the chart that we have seen up there, there is a sinusoidal, which is get that this baby had anemia. And cerebral hemorrhage can occur because of trauma or sometimes fetal coagulopathy or alloimmune thrombocytopenia or sometimes infection, vascular malformation, tumor, or any hypoxic ischemic stroke. But in most of cases, this is some of rare cases, which is incidence of 1 to 2 on 100,000. And most of the cases of this fetal intracranial hemorrhage occur in the early third trimester because of immaturity of graminar matrix and susceptibility to change in cerebral blood flow. As you remember when you see on the video, the effect of contraction as well and circulation in the brain. So all these are typically in uterointracranial hemorrhage, also classified in grades, and with increase of poor prognosis, it might accompany with a high grade of hemorrhage as well. So there is several other causes of cerebral injury, like the way I said before, and also for this case, as you can see, there is a fetal MRI which is also revealed the large bilateral hemispheric parenchyma hemorrhage. So according to the history, if you really remember the history of the mother, they have this condition. She had her brother had a thrombocytopenia as well, so it's some kind of heritable, and that's what we can see in this case. But similar to intracranial hemorrhage, the appearance of fetal stroke is also variable, though initially it appears increased cerebral echogenicity as well. So as you can see, when you do monitoring of fetal heart rate, especially when you use advanced device like CTG, and if you interpret timely, it will guide you on what to do by that time and save the lives of these babies. Because when someone don't know how to interpret these findings, it may be a problem, because when you see the fetal at it's 140, fine, it is within the baseline, but there is no viability there, because we expect the normal viability to between 6 to 25 beats per minute, and sometimes you might find there is a loss, which is the flat line, and that indicates that it's classified in grade 3, category 3, I mean. So intervention might be done based on not a single reading. So like, as you can see in this case, this mother had a test before, but there was no any intervention done. So when she came back, then the condition she was even worse, but the results that we get, the outcome of this baby, that the baby is called well 6 to 8, which is okay, but that also doesn't tell that baby we're doing fine by that time, because when you do other investigation, furthermore investigation, then you can find that other condition on behind that, like the way we see in this scenario, there is ultrasound done and MRI as well. So that's the first case. And when you're going to look on the second case study, we have also a woman who is 40 years old. I think this is an African one. She's 40 years old. She's gravida 3 para 1, living 1, and had 1 abortion. So she was admitted with a GA of 39 weeks plus 4 days, and she had a history of prior cesarean delivery due to large gestation age, and the baby was also macrosomic. So when she was arriving in labor and delivery, describing a trial of labor after cesarean section, and she was presented with contraction. On vaginal examination, find out that the cervix was 2 centimeters dilated, but also she denied leaking of fluid or vaginal bleeding, and reported normal fetal movement. When you look on her story, it includes she had fibroids before, and she had also sexual abuse in the distant past. Also, her most recent ultrasound scan were performed 1 week ago and showed estimation of fetal weight of 3.7 kg. So on admission, the temperature was 36.7 degrees of Celsius, and heart rate was 75 beats per minute, pulse rate 124 over 89 millimeter of mercury, respiratory rate is 18, and prenatal laboratory finding were within a normal limit. After admission, the patient was also attached with the CTG monitor, and these were the findings that we have been noticed. So as you can see on the chart, on the upper part that we show the fetal heart, I'm not so sure if it's seen clearly, but the baseline there of the heartbeat is 150, as you can see, and viability also is there, and it's moderate. It's moderate because it's when you look it properly, it's over 25 beats per minute in between those boxes. So also there is some kind of acceleration there. So when you see on the fetal, there is acceleration pattern as well, and contraction was irregular, as you can see on the below chart there. There is irregularity of contraction, which is appearing 3 times. 3 times to 5 minutes apart, as can shown here on this picture. But also the interpretation for this tell us there is a category 1 tracing, and reflective of fetal well-being, and there is an absence of metabolic acidosis somehow, because viability is there. So there is variable you can see on the reading. There is more like 2 readings, which has variables. And so to that, tell us that this woman is because the contraction is there, so she's in labor, and the plan after cervical examination, there was no change on cervical dilatation, and the plan it was to augment with oxytocin, but they have to titrate it according, because she had also previous cesarean section. At the first, patient was amenable to the plan, but she changed her mind and refused oxytocin and any other intervention and wishes to go home. So the physician discussed the concern of our patient and her husband as well, and informed that of the risk of she has a risk of uterine rupture with a history of cesarean section she had before, and with a macrosomic infant. So the patient and husband verbalized their understanding, but again they refused treatment. So signed a discharged form and left the hospital. After 3 days, the patient returned in labor and delivery, and she came with a painful contraction that she rated as 8 out of 10 and requested a pain relief. And when the PV examination done, also they find out that the cervix is still 2 centimeter dilated and there is effacement of 30%, but also the head, it was still high, which is level, station -3. So she concerned taking an epidural, but was hesitating to do so because she believed it was the reason she had a cesarean delivery before. And when she did not progress past 3 centimeter after epidural placement, and this was the finding of the pattern of the fetal heart. As you can see, the fetal heart, it was high. There is almost about the baseline rate, it was about 170 beats per minute. So the baby had fetal tachycardia, and we term is at fetal tachycardia because it's, as you can see, there is a flat line which is more than 10 minutes, and it was 170, and there was no acceleration with no viability. Just there is only 1 point of acceleration, but there is no viability as well. So on a episodic pattern, there is no, and periodic, she had only late peeling deceleration, just there is late deceleration there, and a uterine contraction, it's appeared there, but it's mild. It was about, it comes up to almost 30, and it's appearing 2 times or 20 something, sorry, it appeared 2 times, which is a part of 3 minutes. And on this interpretation, so this is category 3, which is category 2, sorry, this is category 2, which is intermediate. And as previous noted, so this patient, it might be had maybe ruptured uterus. So we, due to that finding of the fetal heart and the discussion were done, and planner for cesarean delivery. So she also refused, and she was kind of a bit complicated patient. So after 1 hour, the fetal heart demonstrated periodically of minimal viability and recurrent prolonged deceleration, which is also is not as you can see, there is a viability, but it was undetermined. And as you can see from there, that the uterine contraction, there is no more uterine contraction, and the decision was made to do cesarean section for this patient because there is no contraction and there is a recurrent prolonged deceleration, which is not a good sign for this baby. So this is, according to interpretation, this is category 3, and this is due to maybe compression for a long time, or prolapse as well, or sometimes uterine rupture. So this, according to this finding, suggested that might be uterine rupture because there is no more uterine contraction. So the plan it was to go for cesarean section, and this is the final tracing of in operating room. You find out there is no contraction as well, but also the fetal heart is low. As you can see, the baseline, it's bradycardia. The baseline, it's bradycardia. It's about almost 65 to 80 beats per minute. So it was unable to determine pattern, and no contraction as well. So the cesarean section were done, and placenta was not noted to be completely separated from the uterus. Also, the uterus were emptied and contracted down. So the fetus and placenta were found in the left upper quadrant, superior and behind the uterus, which is suggested a uterine rupture. So the head were delivery and followed by torso within 2 minutes. So she had a female infant, but viable, pale, floppy, and hypnic female infant was delivered and handed to neonatal ICU team. So the baby weight is 4 kg with APGAR score of 1 due to good resuscitation skills. So after 5th minute, the baby score 8, and the infant was received positive pressure ventilation for 2 minutes with a rapid improvement of heart rate. And the infant started to breathe spontaneous and cried. Finally, deep suction yield copious amount of bloody fluid because of this ruptured uterus. So as you can see, the finding of cold gas were done, and she was taken to NICU. So as we can see, the cases that we discussed here, we all noticed that there is an importance of continuous fetal monitoring, though you can use a different device. You can use a CTG, or you can use a MOIL, you can use ultrasound Doppler, or a penile fetoscope. But the important thing is to notice that if there is any variation, if there is any deceleration or acceleration, that you might find the acceleration is normal, but when there is a deceleration, then you have to rule out what kind of deceleration is that. If it's rate, if it's area deceleration, or it's a variable. So when you find there is deceleration, also you have to know that the cause of that, it might be what. Then you have to go further and see if there is late deceleration. Maybe you have to know that there is uterine placenta insufficient, and you have to act accordingly. So thank you so much for listening. This is the end of my presentation.
Okay.
And I welcome you back, Dr. Gabon.
Yeah, so after listening to that second case study, I'm just feel like helpless. Because I feel like jumping up after I see that strip. I'm like, oh, somebody's doing something. Somebody's doing something. I'm like, oh God, I'm sitting, I'm squeezing my hands, but whew, no, thank you very much for sharing that. But yes, fetal monitoring, as Dr. Emma said in the beginning, and you emphasized there, and Professor Brown added to it, is a tool that can help us, but that does not excuse us or relieve us from our responsibility to be responsible for that mom and a baby. So all the assessment or diagnostic tools we can use to help us guide the diagnosis, but still we have to be vigilant for these mom and babies. And there's a lot of things that we can do to help this mom, especially the second one. Yes, probably she needed more education than anybody else, because she was saying no to things that you know for sure are gonna increase the compromise the baby, because if she goes home, previous C-section or that history, yeah, she needed more information than anybody else. But it's unfortunate that sometimes people don't want to listen and want to do whatever they do. So all we can do is just educate, and give them pros and cons of what the decision, and then let them make the decision no matter what we want them to do. So thank you, the three of you, for presenting an excellent topic here. And as I said, it's much needed for all the labor and delivery nurses and doctors to prepare this mom and make sure they have a safe delivery, and then prepare that baby or anticipate issue that will happen to this baby. So I am going to let people ask questions now from the three of our presenters, please. And then I have my few questions, but I'm going to let other people ask one first. Okay. Anybody has any questions? Nobody?
Oh, I don't have a question, but I do have a comment to say that this was very well put. I mean, we have all the areas of OBGYN represented here. We have a doctor, we have a nurse, we have a midwife. I think that's wonderful because we've heard all these different voices. So this was very powerful, and I'm so glad I was able to share with you all. Thank you. Mr. Jafari Lutavi, I do have a question. That first case where the mom came in with decreased fetal movement, and the strip was not reactive for about 2 hours. I think for me, that would have been a sign that things were not well, because really a reactive strip, I think you should probably have one within 20 minutes. If it is taking that long to get a reactive strip, I think if I was managing that patient, I would have kept her at that time. I don't think I would have sent her home. Maybe I would have done an ultrasound to check the fluid, maybe to do like a biophysical profile. So I don't know if that was ever considered, but I am happy to know that when she came in and she did have that sinusoidal pattern, that quick action was taken and she was delivered immediately. So that was a good response for when she came back the second time around.
Yeah. Thank you for that comment, Dr. Kura.
So anybody with the questions? I know there are a few pediatricians in the group. So, okay, Mr. Mugalu Kitandu. Yes, please go ahead.
Good afternoon. I am not a mister.
I'm sorry.
I am. Okay. I had a question about intervention when the mothers have when the fetus have change in fetal heart rate. When we are hydrating mothers with fetal distress, do we give them any crystalloids, or is there any preferred fluid to rehydrate them? Because where I practice, there is a preference for Ringer's lactate. Now, is there any base for that, or we can add any crystalloid?
My understanding is that you could use lactated Ringers or even normal saline. I think any of them would be a good option. Now, I do believe if somebody has diabetes, for example, maybe normal saline might be a better option than the lactated Ringers. So that's the only caveat that I know, but I think any of them is usually okay.
Yeah, end of term, it's usually okay because the dish there is to increase the circulation of the mother. So if you hydrate the mother, then the circulation will increase and help the baby also to have a good circulation as well.
Thank you very much, Ms. Mugalu, for the questions. Any other questions? But I think also, anytime you have any concern about the baby, and then you have to fix or resuscitate the mom first. So you have to be able to do things to the mom. So yes, fluid is great, but then the problem is you have to know about the position of the mom. If mom is laying back on the laying on her back, that is not going to allow the improved circulation, because you can give fluid as much as you want, but if they're not going to return back to resuscitate the baby, you're wasting your time. So that's why change of position is always the first thing. Change of position or giving food so you can allow the food to go through it. And then of course, Professor Brown did mention, like, if you guys use oxygen and it's available, then if it's needed, then yes, but not necessarily that you just give oxygen for anybody. No, you always have to follow the criteria, what is needed for that part. So yeah, usually as nurses, where you're trying to do any other intervention, just flip mom in either side. We used to say a long time ago, we used to say, oh, you have to go to the left side only. No, some babies, you put them in the left side, they start throwing the D cells or variable. They're like, I do not want that side. So you have to go back to the right side. So either side is always positioning. You know, sometimes if you're by yourself, hands and knees also be perfect. Yeah, as long as they don't have a epidural, so you don't have to like squash the baby. So hands and knees also will release the pressure from the mom's back and then give more room for the baby. And then if you're hydrating, that mom is going to have easier circulation to send the food to the baby. So any position, as long as it's not on the back. Or if you have to stay on the back, then you have to be tilting like one butt cheek with a pillow or blankets or something, just to make sure you alleviate the pressure on the vena cava. So on the back, yeah. Oh, any other questions? Thank you. That was great.
I have a question, but
to add on that, sorry, before Dr. Sambachaka got in, to add on that, but also you can just hydrate your mother and you can change your position, but you can allow a mother to move around. But when you do continuous monitoring, then you can see if there is any changes. But also sometimes you might find that even to give our mother oxygen also is helping to increase blood perfusion as well.
Excellent. Dr. Msabichaka?
well, Zoom won't let me raise my hand because I think they don't want me asking questions. But but I wanted to thank you, Professor Brown, Dr. Kulwa, Mr. Jafari, for this very wonderful educational talk. As a pediatrician, my heart was racing as well with Mr. Jafari's presentations. My question, though, for from those two scenarios is, I know it's not that often that the NICU team is at the delivery in most of the hospitals in Tanzania. And so I was grateful that the NICU was there, they were informed and they were ready, which is what I would be there practicing in the US, and I would be informed and ready to expect a baby in distress. What are some of the things that are currently be done or could be done if you are the midwife and you don't have the NICU team? Because I think these two babies, their outcomes were what they were because immediate intervention was provided to them, positive pressure ventilation, which is key when they come out down like the way they did.
Mr. Jafari?
Thank you, Dr. Lillian, for prompting that question. Actually, this scenario, it's a fund from the hospital, which is well equipped, and actually that's why you can find that even the first case and the second case, that the NICU team was there and even the neonatologists were there as well. But in our contexts, majority, most of the time, this team were not there. So what we're supposed to do is to at least make sure that the nurses and doctors that are around the procedure, they have the capacity to provide a positive ventilation, and also they know the skills on how to help the baby who is not spontaneous breathing as well. So we actually need that, and even to know on how to do a fetal monitoring. This is not just a part of a nurse or a midwife, and even doctors are supposed to know that. And when you know to interpret these findings, and somehow you can intervene due to category that you had by that time. Most of the time, you might find that the woman is just diagnosed as she had an unreassuring fetal status, and they do cesarean section, but they just don't give her the time for monitoring and see whether the fetal will be in will come back in baseline or not. And as an tertiary hospitals or higher facilities, you have to make sure that we need to change the practice as well. When you find out there is a case which is complicated, I mean, for the mother and fetal status as well, so you have to at least to have a pediatrician or have a neonatologist if it's there, or a well-skilled a person from NICU to be there so as to help the baby immediately when the baby is born. So I think we need to do that practice, and that comes after impact knowledge to them and use it effectively.
So I know Buguruni is here, and I know other nurses and doctors from other hospitals other than Muhimbili are here. So my question, for example, is, yeah, so Mr. Jafari shared from the tertiary center, which is Muhimbili Referral Hospital. Excellent. So for the other hospitals who don't have as much resource as the Muhimbili, I know you use the CTG and the fetoscope. Consider that scenario. What can you do on your hospital to try and take care of that patient? Would you be able to do exactly what the Muhimbili provided, or what are the limitations that you have right now if that patient showed up on your hospital? If anybody from Muhimbili or from Buguruni or Mwananyamala, if you can answer that question, that would be great, please. Anybody from Buguruni? Because I know not every hospital has what Muhimbili has. But so if that patient shows up, or those two patients show up on your hospital, would you be able to do similar or exactly what Muhimbili did?
Sorry, Dr. Harriet. As the matter of fact
that the practice that we had is the pediatrician or neonatologist has to stay in the specific ward, and even the labor ward, if they have this kind of patient, they usually don't notify them, and they just monitor a patient. If cesarean section is needed, they just go for cesarean section. After that, the outcome of that baby after maybe resuscitation or what, then they will notify a team from NICU, so that the team will know from there, but not before the woman delivery. So I think if we need to improve so much on that, we need to change the practice. At least we have to notify the high risk patient, and have to make sure that at least we have the person who is capable of taking care immediately of the baby who is not well during delivery.
My concern is that, I do agree that you said people have to improve, but and learn and try to do as much as you can. But you guys have those resources. So the hospital that does not have those resources, they're going to struggle. And that's why I wanted to know if they're presented with that patient, then it might be an issue. But I mean, we can elicit the response from Buguruni and Mwananyamala another time. But that was a great case study, and I appreciate you sharing that so we can learn from that. We are going to share this video when it's we're done, and then so please share to a lot of nurses and doctors, so then we have at least some basic information or review of information that we can take care for these mom and babies and prepare the baby before the delivery. Any questions from the presenters before we finish up? The final words for the presenters, if you want to give us the final words from what you presented, for something that people should take away today. Anybody wants to go first? Going once?
Yeah, I'm just going to say that fetal monitoring is helpful, and fetal monitoring can help to save lives. And so our duty as healthcare providers is to really understand it well, and to know what we need to do when we see a certain kind of tracing, because only if we're able to do that, are we going to use it to its maximum benefit and help for the patients. And that's what we want at the end of the day, healthy babies and healthy moms. So I think it's a good area to focus on and to really make it work well for the patients. Thank you so much for having me. It's been a pleasure to meet you all and to hear the presentations.
No, thank you for an excellent presentation and the foundation of the background of all the fetal monitoring. So we'll call you back. We still have in 2 weeks another session there. So
no problem. I'll be happy to come back.
Thank you.
Thank you.
Professor Brown.
Hi, also I'd like to say thank you for having me. It was a very interesting presentation from everybody. A lot of good takeaways that we have resources with our electronics and then our non-electronic devices, but also our basic nursing care, just touching the patient. That's very important, and we should, not be afraid to do that. It's important. Even when you're using the fetal monitor, you have to touch the patient first so you know where to put that fetal monitor. It's important. So thank you, and I hope to see you all again. It'd be interesting to have a discussion with the nurses that are in Tanzania practicing.
Yes,
It'd be nice to have that discussion.
Yes, that's in 2 weeks. We're going to get few nurses from Tanzania to be able to. Yes, and that's why we need to, I'm going to try and work as hard as I can to get this recording out so they can review it and then get back. We want the presentation from all 3 hospitals. So if we get 2 to 3 nurses in each hospital, that would be great, because we want to get a different perception from different people and see how we can address this. And if there's something that we can do to try and help that, we will try to do it. But we need to know what are you issues with. So thank you, Mr. Sekabe. So Buguruni said most of the cases like this, we can refer to Amana Hospital or Muhimbili. Okay, so then that's what I wanted to know, because if just in case if somebody comes with the high acuity cases, you should be able to identify who you can take care of at your level, and then you need to ship them. So, thank you for providing that. So we just need to hear from Mwananyamala if they're able to do those 2 cases at Mwananyamala, or do they have to ship it to Muhimbili? So thank you very much. So Mr. Mbinda, you want to say anything before I let people go? Yes, we can hear you.
Yes, okay. First of all, I have to say that thank you for all presenters for those presenters. It was so nice. We have learned a lot. And what I think, we have a hard work in front of us for solving this neonatal child. You can see how people are struggling to save the mothers and the neonatal together. So I'm so happy to be to take part in this meeting for today. And then I wish you all the thanks a lot.
Thank you very much, Mr. Mbinda. Mr. Jafari, I'm going to let Mr. Jafari close us with the final words. Came back. So can you close us, sir? give us the final words.
Yeah, first of all, I would like to thank you for making me participate in this. And actually, I'm so happy that we are going to provide this information to more nurses and doctors so as we can save their life. Yeah, so I just want to say one thing, that this woman were just carrying the pregnant for 10 months and they need babies. The one who will help them is us. So we need to monitor them properly. We need to make sure that every woman should go out of labor ward or out of any health facility with her baby safely.
But I want to thank everybody who came in, and thank you for coming in on time. And I know we had a few difficulties in the beginning, but I was excited then, and I'm still excited now that for the knowledge you guys shared today. And definitely we're gonna share with all the nurses and doctors who are taking care of these moms. And then so we can ensure that we know what we're doing with these babies. And oh, go ahead. No, thank you very much. I do agree. As I said, everybody who's going to touch this mom and the baby, we should know what you are doing, because remember, they entrusted us with their life, because any small delay or mistake could lead to the death of the mom or the baby or both. So we really need to have those observant eyes to be able to identify the risk factors, identify when they're deteriorating, and call for help. And then so you can save the mom's and the baby's life. Dr. Mlungu, you want to say anything else before I say goodbye? I know you're busy right at work. Hi. Do you want to say anything? Oh, I can't hear you. You don't.
I have nothing to say. I'm okay.
Okay. No, thank you very much. Mr. Kibona, you want to say anything?
So I've been late to the conversation. At all in all, I've enjoyed it, and I wish next time we're in front line to help the women and their babies to have the. Thank you.
So I appreciate it, Mr. Kibona. Thank you for coming. So I'm with the essence of time. So I want to thank everybody else. As I said, we're going to produce release this video as soon as it's converted, and then the next 2 weeks, July 14th, we're going to have the second part of this discussion for fetal monitoring, and where we want at least 3 participants from each hospitals to be able to participate in that discussion, because we want to learn what exactly you do in your hospital. So if you're willing, from those 3 hospitals, you're willing to be part of it, just please email me or text me. You guys know my number, you have my email. Text me if you want to be part of that, but then we have the conversation prepared to make sure you are ready for that day in 2 weeks. So again, thank you very much. Remember, Mr. Jafai said it well. Those mom depends on us. Those babies depends on us. So we have to know what we're doing to make sure we save their lives. So thank you very much, and I will see you in 2 weeks. Bye.
Kazi nzuri, Daktari Gabone.
Asante.
Asante, bye.
Bye. Oh, I need to know how many people are in Buguruni. Hey,
okay.
You've been quiet all this time. You're supposed to say something.
Who's that?
Dr. Benella, he's hiding somewhere.
I will say next 2 weeks. I'll be ready. I'm preparing to say a lot.
Okay, good. I'm waiting for that.
Thank you.
Thank you very much. Did you have any other people from Buguruni came? The nurses.
From Mananyama.
Mananyama. I'm sorry, Mananyama.
Yes, they joined the separate. Okay, bye.
Well, Kitando, I apologize. Samahani. So in 2 weeks, please, in 2 weeks. So Buguruni, if you can send me how many people came and their names, that would be great, so we can give, when we started giving the little certificate of acknowledgement that you attend the training, then we have the names of the people. So again, thank you everybody, and have a great Thursday. We'll see you in 2 weeks.